You will go on YouTube, search Asphyxia forensic medicine in one shot, and then you'll find a one shot video, probably not this one, some other video. And then when you get into the video, you'll find that the lecturer has started the lecture from hanging. Again, you'll search for another video. In another video also, the lecturer has said 2-3 words about asphyxia and then directly into hanging. Without being taught the concept behind asphyxia, you are being done injustice to. So before getting into the various types of asphyxial deaths, you need to understand first the concept behind asphyxia. What even is asphyxia? What are the types of asphyxia? What are the clinical signs of asphyxia? And what is the mechanism behind those clinical signs? So before getting into asphyxial deaths by hanging, strangulation, suffocation, and drowning, first I'll teach you the definition of asphyxia, the various types of asphyxia, the clinical signs of asphyxia, and the mechanism behind those clinical signs. Starting the lecture with the definition of asphyxia. Definition. So the word asphyxia can be broken down into two, A and asphyxia, where A stands for absence and asphyxia stands for pulse. And that is why the word in Greek literally translates to pulselessness. But then the actual definition of asphyxia is defective aeration of blood. See, this is how the aeration of blood takes place. Here's the respiratory tract, and the end portion of respiratory tract is the alveoli, which is surrounded by capillary. So in between the alveoli and the capillary, there's your respiratory membrane. It is at the respiratory membrane that oxygen enters the blood and the carbon dioxide leaves the blood. If there is any impairment or pathology at the site of ventilation, or at the site of perfusion, or at the site of exchange, or at the site of central nervous system or the center of respiration, then it will eventually lead to defective aeration of blood or reduced oxygen of blood, and that is referred to as asphyxia. So asphyxia, it is characterized by two things. It is characterized by two things. Number one, decrease in oxygen in blood. And number two, increase in carbon dioxide in blood. So there is less oxygen but lots of carbon dioxide. This is referred to as hypoxia, and this is referred to as hypercapnia. So in asphyxia, you have a combination of hypoxia and hypercapnia. So finally, what is asphyxia? Asphyxia can be broken down into A and asphyxia, where A means absence and asphyxia means pulse. So in Greek, it literally translates to pulselessness. By definition, it is defective aeration of blood which can be due to pathology or impairment at the site of ventilation, or at the site of exchange, or at the site of perfusion, or at the site of respiratory control center. It is characterized by two things. Number one, hypoxia. Hypoxia means a decreased oxygen in blood or the inability of the cell to utilize oxygen. And number two, hypercapnia, which means increased carbon dioxide load in blood. Done. Number two, what are the various types of asphyxia? Now, the various types are on the basis of causative agent, which is also referred to as asphyxiant. On the basis of what causes asphyxia, you have the various types of asphyxia. Number A, mechanical asphyxia. As the name says, in mechanical asphyxia, there is mechanical obstruction to airflow. I will not give you any examples because throughout the lecture, you are going to learn about lots and lots of mechanical asphyxia due to hanging, due to strangulation, due to suffocation, and due to drowning. Number two, traumatic asphyxia. So, traumatic asphyxia is due to pressure on chest. For example, in case of stampede, when lots of people are running over you and stepping over your chest is unable to inflate, your lung is unable to expand, and you are unable to breathe in, leading to asphyxia. Or a fall of building on body during earthquake. So during earthquake, building, it collapses over your body and the same thing happens. You are unable to breathe, leading to traumatic asphyxia. Another is tension pneumothorax. Tension pneumothorax. What is tension pneumothorax? See, in tension pneumothorax, here's your lung, here's the pleura around the lung, and then in between is the pleural cavity. Due to trauma to the lung, the air from inside the lung escapes into the pleural cavity. As a result, the pleural cavity is now filled with air. This air does two things. Number one, it compresses the lung. As a result, the lung is unable to expand. Number two, the pleural cavity normally is a vacuum with little fluid. It's a vacuum with little fluid. Due to this vacuum, there is negative intrapleural pressure which pulls the lung, and due to the negative intrapleural pressure, the lung is able to expand. But once this pleural cavity is filled with air, that negative intrapleural pressure is lost. So the lung is unable to expand. So at the end of the day, the lung is unable to expand due to two reasons. Number one, the air in the pleural cavity is compressing over the lung. And number two, the air in the pleural cavity removes that negative intrapleural pressure responsible for the expansion of the lung. Okay, so that was your traumatic asphyxia. After traumatic asphyxia, you have chemical asphyxia. See, straight up, it's due to poisoning. For example, you have carbon monoxide poisoning. You know very well that the hemoglobin in your blood has a large affinity towards carbon monoxide as compared to oxygen. So if you get poisoned with carbon monoxide, the hemoglobin is going to leave the oxygen, go attach with carbon monoxide, and there is decreased availability of oxygen to your body, leading to asphyxia. Another poisoning is cyanide poisoning. You know that cyanide is cytotoxic. It works by inhibiting the oxidative phosphorylation responsible for utilization of oxygen to produce energy in mitochondria. So cyanide will go and inhibit oxidative phosphorylation even if there is oxygen. Even if the cell is available with oxygen, the cell won't be able to utilize that oxygen and energy won't be liberated, leading to asphyxia. The rest are opium/barbiturate poisoning. Opium and barbiturate, they are CNS suppressants. That means they will go and act in the central nervous system where there are your respiratory center and suppress the respiratory center, hence suppressing the mechanism of respiration, hence leading to hypoxia and asphyxia. Next is your environmental. Environmental asphyxia is as a result of reduced oxygen in environment itself, reduced availability of oxygen. For example, at high altitude, there is reduced atmospheric partial pressure of oxygen. Similarly, deep in caves or in well, there is more carbon dioxide and less oxygen. So your body receives less oxygen and has more carbon dioxide. Then there is pathological asphyxia. Pathological asphyxia, straight up, it is due to some sort of pathology or disease of respiratory system, either in the tract or the lung itself. For example, glottis edema. When there is edema of the glottis, there is narrowing of the glottis, the air can't pass in. Another, in pleural effusion, the same concept as in pneumothorax. In pneumothorax, the pleural cavity was filled with air which inhibited the expansion of the lung. In pleural effusion, the pleural cavity is filled with inflammatory fluid inhibiting the expansion of lung by two ways. What? Number one, by compressing the lung. Number two, by obliterating the negative intrapleural pressure. And finally, another example could be pneumonia. Why pneumonia? In pneumonia, there is consolidation of lung. That is, the alveoli is filled with inflammatory fluid. And if the alveoli is filled with inflammatory fluid, exchange of gases won't take place. And with that, we are done with the definition of asphyxia and the various types of asphyxia. What are the various types of asphyxia? We have the mechanical, traumatic, chemical, environmental, and pathologic. Next, what are the various signs of asphyxia? So you have something called asphyxial triad. So there are three major signs of asphyxia, and they are cyanosis, which is in the form of external finding. Number two, Traudeuse or Bayard spots. They are in the form of external and internal findings. They are nothing but the petechial pinpoint hemorrhages and visceral congestion. Since this is present in viscera, which is inside your body, obviously this is going to be in the form of internal finding. This is your asphyxial triad. After that, there is also something known as asphyxial quintet. So it should contain the triad plus two more signs, 1 and 2. First one is post-mortem fluidity of blood, that the blood becomes thin and fluid, and right ventricular enlargement. Both of them are indeed your internal finding. One is the finding of the blood and the other is the finding of the heart. Again, so you have the asphyxial triad, asphyxial quintet. Others, asphyxia also leads to relaxation of sphincters. And if the sphincters are going to get relaxed, there is going to be voiding of three things: voiding of urine, voiding of stool, and voiding of semen. That is why in victims of asphyxial death, along with the body, you might find voided urine, voided stool, and voided semen. So what do we have? We have asphyxial triad containing of cyanosis, petechial hemorrhage or Traudeuse or Bayard spot, and visceral congestion. Asphyxial quintet containing the triad plus 2, post-mortem fluidity of blood and right ventricular enlargement, and other, that is the relaxation of sphincter leading to voiding of urine, stool, and semen. Little bit of exercise for you. What is this? This is cyanosis, bluish discoloration of nail bed. What is this? This is the Traudeuse spots. Where are the Traudeuse spots present here? It is present in the epicardium. Again, what are these? These are again the same Traudeuse or the petechial hemorrhages. Where are they? They are present in the conjunctiva. So I said earlier, it can be an external finding as well as an internal finding. So right now, these Traudeuse spots, they are your external finding. Where are they? They are all around the eyelids. What is this? This is again your Traudeuse spots. Here, where are the Traudeuse spots? They are just below the pleura, subpleura. And finally, what is this? This is the visceral congestion in the form of pulmonary edema. Okay. Now you will tell me that I am doing injustice to you guys without explaining you how exactly does a person with asphyxiation end up having cyanosis or visceral congestion or Bayard spots or post-mortem fluidity of blood or right ventricular enlargement or the relaxation of sphincters. And hold your horses. because I'm going to explain to you how now. This is how. Listen to me, you talented piece of people. Okay. First, there is asphyxia. Whenever there is asphyxia, there is eventually hypoxia. By hypoxia, that means there is less oxygen in blood. As a result, there is less oxyhemoglobin and the blood becomes bluish, and this is referred to as where is the slide going? This is referred to as cyanosis. There you go, the very first clinical sign, cyanosis. Second, if asphyxia, I repeat, if asphyxia is due to, I wanted a straight line. If asphyxia is due to neck compression, that is somebody compresses your neck and then you get asphyxiation. In that case, along with the neck, what is also being compressed? What is here? What is superficially here? There is jugular vein. So the jugular vein also gets compressed. There is compression of the jugular vein. With compression of the jugular vein, there is reduced drainage because you have obstructed the jugular vein. So the blood from the head and neck does not get drained. You have obstructed that draining pathway, okay? Reduced return. But the arterial supply is normal. Arterial supply is normal. What else causes reduced drainage? Okay, I said if there is asphyxia due to neck compression, there is also compression of the jugular vein which leads to reduced drainage. But what if asphyxia is not due to neck compression, it is due to some other mechanism? In that case, asphyxia will lead to abnormal breathing. Let's say it's a case of stampede or a wall has collapsed on you. You will try to breathe, you are unable to breathe. There is too much pressure inside the intrathoracic cavity, or maybe there is a case of choking, that is, a food has lodged in your respiratory tract. You will try to breathe, you are unable to breathe, you suffocate. There is too much intrathoracic pressure. So there is abnormal breathing, and there is changes in intrathoracic pressure, and that will eventually lead to the same thing. That will also lead to reduced drainage. Okay. Now, see, here is your capillary. This capillary is receiving normal arterial flow, but at the vein side, it's blocked. That means the venous drainage is not there, but then the oxygenated blood is continuously going. So lots and lots of blood will pool into the capillary, which will increase the hydrostatic pressure and build up pressure inside the capillary. There is increase in hydrostatic pressure, and this increase in hydrostatic pressure will lead to the rupture of the capillary rupture. Another you can understand right here. See, hypoxia, you might already know, leads to peripheral vasodilation. With peripheral vasodilation, there is stasis, and stasis also results in increased hydrostatic pressure, eventually leading to capillary rupture and your Troud's spots. Okay, fine. See, first there was neck compression. Due to neck compression, the drainage was inhibited, but then the arterial supply is still there, leading to increased hydrostatic pressure inside the capillary, and then the capillary bursts. Simple. Stasis also leads to, if the stasis is inside visceral organ, it also leads to visceral congestion. That's your third sign. So with this, you are done with the asphyxial triad of cyanosis, Troud's spots, and visceral congestion. Now we have the quintet, the two others. So first was postmortem fluidity. Due to asphyxia, there is increased fibrinolysin. And if there is increased fibrinolysin, obviously there is more fluidity of blood. There is increased fluidity of blood. Second, hypoxia leads to peripheral vasodilation, but you must also know that it leads to pulmonary vasoconstriction, which eventually leads to pulmonary hypertension. And when there is pulmonary hypertension, there is increased resistance in the pulmonary artery. So the right ventricle has to contract harder to push the blood inside the highly resistant pulmonary artery. And the overworking of the right ventricle leads to right ventricular hypertrophy, also referred to as the right ventricular enlargement. Right ventricular enlargement. So now you also have the two quintets: increased fluidity of blood and right ventricular enlargement. Finally, due to asphyxia, the muscles they lax. Muscles lax or relax, and the sphincters they relax. Sphincters relax, and that is why there is voiding of urine, stool and semen. And that is how each of the signs of asphyxia are precipitated. This is the pathophysiology or the mechanism behind each of them. Are we good? Okay, now we are good, right? I hope I have done justice to the topic now. So now we can finally move on to hanging. All right. What is hanging? Definition. Hanging is asphyxia. It is mechanical asphyxia due to neck compression. Due to neck compression, the compression of neck is by a ligature, which is around the neck, and for the ligature, the constricting force is the weight of suspended body. See, this right here, this thing is your ligature. If I wrap this ligature around my neck, right, and then suspend myself on the ceiling, then due to the weight of the suspended body, this ligature will compress around my neck, and this will eventually lead to asphyxia. So hanging is asphyxia due to neck compression by a ligature around the neck, for which the constricting force is the weight of the suspended body. What is the mechanism of death? See, since in hanging the neck is getting compressed, let me draw the transverse section of the neck. When I draw the transverse section of the neck, I get the esophagus. Right in front of the esophagus is your trachea. Here's the trachea. And behind the esophagus is the cervical vertebra. No bueno, cervical vertebra. And at the tracheoesophageal groove, this right here, is the carotid sheath. On either side, carotid sheath, and both of them contain the carotid artery, which is medially, the jugular vein, which is laterally. Whoa, where did the carotid artery go? And then vagus nerve posteriorly. So when the neck is compressed, each one of these structures get compressed depending on how much force is constricting the neck. So most superficially, you have the jugular vein. So the compression of the jugular vein requires only 2 kg of force. Medial to that is the carotid artery. And the compression of the carotid artery requires a little more, that is 5 kg of force. Then posteriorly is the vagus nerve. Give me a straight line. there's your vagus nerve. So your vagus nerve can get compressed as well. Then here is your trachea. The compression of trachea, the tracheal compression, requires more force, around 15 kg. And finally, there's your cervical vertebra. Cervical vertebra. Vertebral compression requires a lot more pressure, around 30 kg of force. Now, the compression of each one of them lead to death by different mechanism. For example, if a jugular vein is compressed, this is going to lead to cerebral congestion. Pretty logical. Jugular vein is compressed, the venous return is blocked, the face and neck is pooled with deoxygenated blood, the cerebrum is pooled with deoxygenated blood, there is cerebral congestion. Carotid compression. If you compress the carotid, the arterial supply to the cerebrum is cut off, leading to cerebral anemia or cerebral hypoperfusion. Similarly, if trachea is compressed, the airflow is inhibited. If vertebra gets compressed, it will lead to the fracture of the vertebra. And if vagal nerve gets compressed, if vagus nerve gets irritated, it will lead to vagal inhibition of heart. Now, out of all these mechanisms, the most common mechanisms for the death by hanging is these two. Most common mechanism of death by hanging. That is the tracheal compression leading to airflow obstruction and the jugular vein compression leading to cerebral congestion. Good. So we are done with the definition, we are done with the mechanism. Now we need to understand the various types of hanging. First, we have on the basis of degree of suspension. See, you can look in this picture. In A, it's the complete body of the person that is suspended or hanging. In B, only parts of the portions of the body is suspended. It's not the complete body is suspended, and here none of the body part is suspended. If there is complete suspension, we call it complete hanging. If there is partial suspension, we call it partial hanging. The differences are, in complete hanging, it's the complete body that is suspended. In partial hanging, only parts of body is suspended. In complete hanging, there is no contact of the body with the ground. In partial hanging, certain parts of the body are in contact with the ground. In complete hanging, the constricting force is the complete weight of the body. In partial hanging, it's the partial weight of the body, only the weight of that part of the body that is actually suspended. Since in complete hanging, the constricting force is larger, it's the weight of the whole body, the duration of death is also faster. Since in partial hanging, the constricting force is less, it is only the part of the body that is suspended, so the duration of death is also slower. Next is on the basis of position of knot. If it is on the occiput, right here, then that's typical hanging. If it is anywhere else other than occiput, then that is atypical hanging. So typical hanging is when there is knot at occiput. Atypical hanging is when there is knot anywhere else other than occiput. For example, it can be submental, just below the mental, or it can be at the jaw angle, below the ear, jaw angle, or anywhere between submental and jaw angle. See, on the basis of manner of death, Hanging can be a cause of suicidal death or homicidal death or accidental death. And in fact, it is the most common method of suicide. The second most common being poisoning, homicidal. Now, under homicidal as well, you have two types. You have judicial hanging and non-judicial hanging. Under judicial hanging, you have the judicial hanging, and under non-judicial hanging, you have lynching. So you might have seen in movies, or you might know from your concept of law about judicial hanging. In judicial hanging, the person is stood on a platform. He puts his head inside the ligature, and the platform then opens such that the person drops down and starts hanging. Okay. In judicial hanging, the knot is ideally submental, but in India, the knot is at a jaw angle. What is lynching? So lynching, it has a really bad history. So lynching refers to someone being hung in the public, in a public setting. So you can see here's the public, and then here's the person who has been hung. So there's the history of African American or black people in general being hung for crimes that they are accused of. Now, these crimes that they are accused of were usually really petty, small crimes, or sometimes, or most of the times, those were just false accusations. And obviously, due to racial profilation and racial injustice, they used to be hung, and then people used to celebrate this. That was lynching. Okay, next is accidental. The example of accidental is autoerotic asphyxiation. Now, this is really interesting. Okay, I want you to concentrate in this topic, or even if you don't concentrate, I know for a fact if I start explaining about autoerotic asphyxia, your concentration will increase on its own. Autoerotic asphyxia. Yes, as the name says, here the person is asphyxiating himself for sexual gratification. This is also referred to as sexual asphyxia, asphyxiating himself for sexual gratification, or asphyxiophilia, loves asphyxiation, or hypoxiphilia, loves that condition of hypoxia or cerebral anemia or cerebral ischemia, or corpswarism. Now this word has a history of its own. I want you to check it out. This gives you the history of the very first recorded event of autoerotic asphyxia. Pretty interesting story it has. Okay, so let's look at the mechanism behind it. How exactly does a person get aroused by asphyxiating himself? So there is partial neck compression, due to which there is cerebral hypoperfusion. Why? Because the carotid has been obstructed, so there is less flow of blood in the brain, which leads to cerebral transient ischemia, temporary ischemia, and this transient ischemia provides hallucinations, and hence sexual gratification. And after receiving sexual gratification, the person then loosens the ligature. Okay, but sometimes this is what happens. The person ties himself with the ligature. There is cerebral ischemia. This person gets hallucinations and then sexual gratification. Then he loosens the ligature. Then he breathes in. Okay. Again he tightens the ligature. Again there is cerebral hypoxia. and then sexual gratification, and then again he loosens the ligature. He does that again and again, and then enjoys himself, gets all the sexual gratification he can receive. When all of a sudden, he's now unable to loosen the ligature. It's stuck. It's stuck. Now it's no longer about sexual gratification. It is about life and death. It is stuck, right? So he tries to loosen the ligature, but it is stuck. So he ends up killing himself accidentally. This is your accidental hanging. So fails to loosen the ligature. Usually in such cases, if you look at the surrounding, you will find four things. Number one, a naked body, because the person is trying to get sexual pleasure. Number two, some pornographic stuff around. Number three, no suicide note. If it were a suicide, he would have written a note. And number four, probably transvestism. Transvestism is when a male wears female cloth and a female wears male cloth. So you can look at the site. There's the naked body, there's the evidence of pornographic material, and there's no suicide note. And this is kept under something called masochism. Masochism is where the person enjoys himself or gets sexual gratification or gets sexual pleasure by inflicting pain on himself, inflicting some sort of pain or embarrassment, all that stuff. That's masochism. All right. So those were the various types of hanging. Number one, on the basis of suspension, you have complete hanging where the total body of the person is elevated or suspended, or incomplete hanging where the body is hanging partially, that is, some part of the body is in contact with the ground. Number two, on the basis of knot, you have typical hanging where the knot is at the occiput and atypical hanging where the knot is everywhere else other than the occiput. And then on the basis of manner of death, suicidal, which is the most common method of suicide, homicidal like judicial hanging or lynching, and accidental where you have autoerotic asphyxia. In autoerotic asphyxia, the person asphyxiates himself in order to gain sexual gratification or sexual pleasure from cerebral hypoperfusion, from cerebral transient ischemia. But while doing so, sometimes eventually he fails to loosen the ligature and ends up hanging and killing himself. Okay, next, post-mortem findings, which this is even more important for you to know. Post-mortem findings, they are divided into two: the external findings and the internal findings. The external findings, you can just see them. Internal findings, you need to carry out autopsy, that is, you need to cut open the body. In external findings of hanging, you need to first look at the face, then look at the neck, then look for hypostasis, and then look for external signs of asphyxia. Starting off with the face. In the face, number one, you look at the appearance of the face. Appearance. The face can either be pale or congested. It is pale if the carotid gets compressed, because that will lead to reduced oxygenated blood, and then hence there's pale, requires around 5 kg of force. Congested when jugular vein gets compressed, because if jugular vein is compressed, there is inhibition of return, and then that leads to congestion with deoxygenated blood, requires around 2 kg of force. B, after appearance, that is this overall color of the face, you look at drooling of saliva. Drooling of saliva. And very important, this is the surest sign of antemortem hanging. See, as a forensic medicine expert or a detective, you need to be able to differentiate between antemortem and postmortem hanging. The person could have died because of hanging, that is, he was alive before hanging, that is antemortem hanging. Or the person could have been killed and then hung with a rope, that is post-mortem hanging. So to differentiate between the two, there are certain signs, and these are the signs. The first one and the surest one being the drooling of saliva. See, this is what happens. When the person hangs himself, right? The person is alive and now he hangs himself. What happens is that on the dependent side, for example, I am hung like this. This is the dependent side. On the dependent side, the submandibular gland gets irritated and there is excessive production of saliva, and then this saliva drools out of the mouth. Now, depending on which position my head is tilted towards while hanging, the saliva will drip on the same side because of gravity. So if my head is like this, the saliva will drip like this. If my head is like this, saliva will drip like this. If my head is like this, the saliva will drip like this. So that's the surest sign of antemortem hanging, drooling of saliva. Why is there drooling of saliva? Cause of the irritation of submandibular gland on the dependent side. See, let's say I was killed before and then my body is hung. Now, no matter how much pressure is exerted on the submandibular gland, it's dead. There's not going to be production of saliva. There's not going to be any drooling. Number C, protrusion of tongue. During hanging, the pharyngeal apparatus gets lifted up, resulting in protrusion of tongue due to the elevation of pharyngeal apparatus. Number D, lay facie sympathetic. Now, this is also a sign of antemortem hanging. Remember, the surest sign is drooling of saliva, the surest sign, but this is also a sign. What happens in lay facie sympathetic is that, see, again I am hung. Today I am being hung way many times. Okay, gotta do this much in order to teach you, right? Okay, as I am hung, again on the dependent side, not just the submandibular gland gets irritated, but the cervical sympathetic chain gets irritated as well. As a result, there is opening of the eye and the dilation of the pupil on the ipsilateral side of the same side. See, the dependent area basically refers to that area of the neck that is receiving the actual pressure, the most pressure. That could be here, or maybe if the knot is fixed here, it could be at the site of knot. Okay, with that being said, again, so on the dependent area, either both the submandibular gland is irritated and the sympathetic cervical chain is also irritated. So here what happens? There is irritation of cervical sympathetic chain that results to opening of eye and dilation of pupil on ipsilateral, that is the same side, ipsilateral side. Okay, see here. So this is the revision for you guys. You can see that the face is pale because the carotid arteries have been obstructed or compressed. Second, you can look at the protrusion of the tongue. Third, you can look at, let me draw here, dribbling of saliva, the drooling of saliva. And then you can look that the eye is open and the pupil is dilated on the ipsilateral side where the knot is putting pressure on, right? This is referred to as lay facie sympathetic. With that, we are done with the face findings. Next, the neck findings. On the neck, due to ligature, you get ligature mark. And what is a ligature mark? If you have seen my video on mechanical injury, you can say fatafat that ligature mark is ligature abrasion, which is nothing but a pressure abrasion. What is pressure abrasion? Pressure abrasion is abrasion due to perpendicular force where the force is less for a long period of time. I won't explain that here. That was supposed to be remembered by you after watching my mechanical injuries video. Okay, so you get pressure abrasion. Now, the characteristics of pressure abrasion depends on number one, or the characteristics of ligature mark depends on number one, the material used. The material can either be soft and wide. For example, dupatta, it is soft and wide. So the ligature mark is also superficial and wide. Or it could be hard and thin, like a wire. Then it would be, the mark would be deep and narrow. This is also referred to as cheese cutter method. Okay, let me show you some of the materials that can be used as ligature. You can use soft material, which will give you a superficial mark, and a hard material, which will give you a deep mark. Soft material like bedsheet, dupatta, sari, any piece of cloth. Hard material like electric wire or rope. So first was your material. Second is your knot and noose. There are two types of knot and noose. Number one is a slip knot with runny noose. Just hear me out, I'll explain you. Slip knot with a runny noose. Number two is fixed knot with fixed noose. Fixed noose. Question number one. What is a knot? What is a noose? So this right here is the knot where the ligature has been tied. And the rest of the ligature around your neck is the noose. Good? Good. So first is a slip knot with a runny noose. So here what happens is that, so here's the ligature around the neck and the knot right here is a slip knot. As a result, when you hang yourself, due to the weight of the body, the slip knot, it slips downward. See, it's slipping downward. As weight is being exerted, it's slipping downward, slipping downward, slipping downward, slipping downward, slipping downward, and eventually it wraps around the neck like this. It wraps around the neck like this. See what has happened? Two things has happened. Number one, the ligature is wrapped completely around my neck. Is there any gap? No. Number two, the ligature was like this. But then as the slip knot slipped down and the noose ran around my neck, it became transverse. So it's now transverse and complete. So slip knot with runny noose gives complete transverse ligature mark. Okay, another. This right here has a fixed knot with fixed noose. That means if I hang myself, it's not gonna slip down. And if it's not gonna slip down, it's gonna be, the ligature is gonna be oblique. Okay, let me show you from the side. The ligature is gonna be oblique and there's space in between, that is incomplete. So this results in incomplete oblique ligature mark. Number C, the color of the ligature mark. First, the ligature mark is pale due to lack of blood supply. Eventually, it becomes dark brown, parchment-like. Okay. Now, a ligature mark due to hanging most of the times possesses these characteristics. Number one, it is oblique. Number two, it is incomplete. Because most of the times the person, they use a fixed knot with a fixed noose, right? Fixed knot with a fixed noose because it is easier to make. People don't know how to make a run, you can just slip knot with a runny noose, right? They know how to make fixed knot with fixed noose. As a result, when they hang, they hang like this. So as they hang like this, they get a oblique, they get a oblique ligature mark and an incomplete ligature mark. Number 3, there is suspension peak with the ligature mark as well. Suspension peak. What is suspension peak? So at this point you can see that the ligature mark is going obliquely up, and then there is a gap in between, and then it looks like an inverted V. So this shows the point of suspension of the neck. So just like here, this is where the knot is tied, and then here's the ligature, giving us this inverted V and showing exactly the point of the neck where the suspension of the body takes place. This is referred to as the suspension peak. This is the site of knot, the site of suspension. Okay, so it's oblique, it's incomplete, and it has a inverted V like suspension peak. But then there are conditions where you get transverse ligature mark. And there are 2 conditions where you get transverse ligature mark. Number 1, when you have a slip knot with runny nose, as I showed earlier, slip knot with runny nose. And number 2, when the point of suspension is low. See, this is fixed knot with fixed nose, okay? Oblique, अरे भाई, oblique, transverse. So when the point of suspension is low, you get a transverse ligature mark no matter the type of knot or ligature is used. So low point of suspension. I missed one point. See, number 4. In hanging, the ligature mark is above the level of thyroid. Why? See, even if I ligate myself below thyroid, due to the gravity and the weight of my body, the ligature will eventually slip above thyroid. See here, what is this? This is a fixed knot with fixed noose. And what has it given us? It has given us oblique incomplete ligature mark. What is this? This is a slip knot with runny nose. What has it given us? It has given us a transverse, complete ligature mark. What is this? This doesn't matter the type of knot or the type of nose, whatever, but then it has a low point of suspension. Both of them have high point of suspension. This has a low point of suspension. Due to which you get that transverse ligature mark. All right. Hypostasis. You get glove and stocking hypostasis. Hypostasis is basically the collection or pooling of blood in the dependent part of the body after death. When you hang yourself after death, you are vertically hanging. Okay, you are vertically hanging. Due to gravity, there is pooling of the blood in the hands and legs, giving glove and stock appearance. But remember, glove and stock appearance does not tell you the cause of death. Just because after death a body has glove and stock appearance, that doesn't mean that the cause of death was hanging. A person could have been killed by, let's say, throttling, strangulation, and then hung. In that case also you will get glove and stocking appearance. That is because of the vertical positioning of the body. That doesn't mean he died of hanging, he died of throttling. But then due to the vertical positioning of the body after death, there is glob and stalking appearance of hypostasis. And then signs of asphyxia, which includes your Troudot spots, the external finding, and cyanosis, the external findings. And with that, you are done with the external post-mortem findings of hanging. So first, you saw the face. Number 1, pale or congested. Number 2, la facies sympathetic. Number 3, drooling of saliva. Number 4, protrusion of tongue. Then you saw the neck, which had the ligature mark. The ligature mark depends on the material, it depends on the knot and the nose. Then hypostasis, and then the signs of asphyxia. Next, internal findings. But before getting into the internal autopsy findings, number 1, let's say you found your victim hanging on the ceiling like this. This rope that has been used, knot and noose, is a important evidence for you, and you need to preserve this, because this will tell you whether the death actually took place by hanging or was he killed by strangulation or some other and then hung. Lots of things. Okay, how will you preserve this? The knot is very important, because the knot will tell you the type, running, slip knot or fixed knot, and many other information. So you need to preserve the knot. In order to preserve the knot, you cut the noose farthest away from the knot. And what is farthest away from the knot? Right opposite to the knot. Right opposite to the knot is the farthest away from the knot. So you cut at this point, kachak. After cutting, you will get the two split ends. You tie them together with the help of a separate thread. Plus, you also tie the knot with a separate thread to preserve the knot. So you cut opposite to the knot, and then you tie the two ends together with the help of a thread, and you also tie the knot with the help of a thread to preserve the knot. This is how the ligature is preserved as an important evidence when you find a hanging case. Second, how is the neck opened? See, in case of hanging, neck compression, while carrying out autopsy, the neck is always opened last. See, number 1, the head opened, the abdomen opened, right? You pull the brain out, then you pull the viscera out, and then only do you dissect the neck. The question is why? For a bloodless dissection. Bloodless dissection. See, hear me out. Number 1, bloodless direction. In case of neck compression, the jugular veins are compressed. And if you go ahead and incise and cut the neck first, the jugular vein will rupture and there will be lots of bleeding in the neck. As a result, the evidences, they won't be appreciated easily. So what you do is you first open the head, remove the brain, that will decompress the compressed veins. Similarly, open the abdomen, remove the visceral organs, again decompress the compressed veins. And then when you open the neck, there is no longer compressed veins, the veins have been decompressed, they are relaxed. So you get a bloodless area in the neck. This is referred to as bloodless dissection. Number 2, to avoid Prinsloo-Gordon artifact. What is Prinsloo-Gordon artifact? See, when there is neck compression, there might be trauma to the larynx. And when you look at the anterior or the lateral wall of the larynx and there is bleeding, that is because of trauma by neck compression. But sometimes you will find such bleeding just behind the esophagus, in the posterior surface of esophagus as well. But that, my friend, is not due to neck compression. That is just an artifact referred to as Prinsloo-Gordon artifact, and it might be mistaken to trauma. So your end whatever conclusion you come up with might be disturbed by the Prinsloo-Gordon artifact. So to avoid Prinsloo-Gordon artifact and to carry out a bloodless dissection, you dissect the neck at last. And what type of incision do you apply? You apply either a Y incision or a modified Y incision while carrying out the dissection of the neck. This right here is bleeding behind the esophagus and a Prinsloo-Gordon artifact which can be avoided by bloodless dissection. Okay, now let's look at the internal findings. Remember, for neck compression, internal autopsy findings, they are always under the same headings. They are always under the same headings, and they are from outside to inside. So you already saw skin with ligature mark in external finding. Remove the skin, you get subcutaneous tissue. Remove the subcutaneous tissue, you get the neck muscles. Remove the neck muscles, what do you get? You get bones and cartilage of the larynx, bones and cartilage. Remove the bones and cartilage, what do you get? You get the inside of the larynx. So that's how you analyze it. So the internal finding is first in the subcutaneous tissue. In hanging, the subcutaneous tissue becomes white and glistening. Number 2, you remove the subcutaneous tissue, you will get the muscles, the neck muscles. Now, there is rarely contusion or hemorrhage at subcutaneous tissue or muscle. Because as I said earlier, in hanging, there is less pressure or less force for a long period of time. Contusion and hemorrhage in the muscle of the neck or the subcutaneous tissue is seen in case of strangulation, where more force is being applied. Here, less force is being applied. So in the muscle of the neck, you don't really find contusion or hemorrhage. Then you remove the muscle. What do you get? You get the hyoid bone. You get the thyroid cartilage. And then you get the cricoid cartilage. First, the hyoid bone. The hyoid bone shows fracture at greater cornua. Greater cornu fracture. But this is only in 15 to 20% of the cases. And only when the person is more than 40 years of age. Because at less than 40 years, it is more cartilage. And cartilage, they don't break easily. So here's the greater cornu of the hyoid bone. This gets fractured. Important thing that you need to know is that you can find 3 types of fracture within the greater cornu of hyoid bone. 1, 2, 3. The 3 types of fracture. Number 1 is adduction fracture. Adduction fracture is when the fractured part, they move inside. And this is seen not in hanging, but in throttling or manual strangulation. Very simple logic. In throttling or manual strangulation, your neck is being pressed inward. By the hand, it's being pressed inward. So obviously, when the bone fractures, it will move inward. Then there's abduction fracture, where the fractured greater cornua, they move outward, both of them. This is seen in hanging. And the third is side-to-side fracture. Side-to-side fracture, both the fractured ends, they are to one side, either this side or this side. And this is seen due to swaying while hanging. So when the body swings while hanging like this from side to side, the bone, they also move to one side. Next is thyroid cartilage. So thyroid cartilage fracture is at superior horn. Cricoid cartilage rarely fractures. It doesn't really fracture. It is only when extensive force is applied, So this is seen more in throttling rather than hanging. More in neck compression, throttling by hand, right? Rather than hanging. Then You remove that, you get what? You get the larynx. Inside the larynx, there might be hemorrhage. And if there is hemorrhage, it's on the anterior / lateral surface. Then it is not Prinsloo-Gordon artifact. Again, more common is the subcutaneous tissue with white and glistening and hyoid bone and thyroid cartilage fracture. These are less common. You can see right here, the greater cornu has been fractured, the superior horn has been fractured. Okay. Are we done with the internal findings? No. There is a special type of finding where the internal findings are even more severe. Here you get severe findings, and that is hanging from a long drop. For example, in judicial hanging, as I mentioned earlier, in judicial hanging, the platform over which the person is opens and the person hangs suddenly or drops down suddenly. Let me explain in another way. Let's say a person climbs a tree, he's on a branch, he ties his neck with the ligature and then wraps that ligature around a tree branch. Then he jumps. As he jumps, eventually he will hang, but then he will hang after a long drop. Due to this long drop, what is there? There is a sudden jerk on the neck, sudden pressure on the neck, sudden force on the neck. And this can result in either vertebral injury and carotid injury. In vertebral injury, you have two: injury of the cervical vertebra and the injury of the lumbar vertebra. In the cervical vertebra, you get hangman fracture. Hangman fracture is nothing but the fracture of C2, C3, C4 vertebra. And the fracture is at pars interarticularis. See, these are the cervical vertebra. These cervical vertebra are connected to one another or joined to one another with the help of a body called pars interarticularis. Pars means body, inter means in between, articularis means joint. So it's a body that joins in between the these cervical, in between the vertebra from behind. So as this joint gets fractured, obviously the vertebra is gonna become unstable. That means it will slip easily, and there is slippage of vertebra. There is slippage of vertebra. This is referred to as spondylolisthesis. So there is fracture at pars interarticularis with slippage of vertebra, referred to as spondylolisthesis. Remember, C1 never gets fractured. It's only C2, C3, C4 that gets fractured. C1 never gets fractured. Most of the time, it's C2 that gets fractured, and then C2 slips over C3. Another. This is at lumbar vertebra. At lumbar vertebra, there is no fracture but hemorrhage, referred to as Simon's hemorrhage. Here's the lumbar vertebra, here's the lumbar vertebra, here's the lumbar vertebra, L1, L2, L3. In between are the vertebral disc. In these vertebral disc, anteriorly, hemorrhage takes place. You can see right here. Here's the vertebral body, lumbar vertebra, lumbar vertebra, lumbar vertebra. In between are the intervertebral disc, and anteriorly there's hemorrhage on the intervertebral disc. This is Simon's hemorrhage. What about carotid injury? In carotid injury, you get the Amuset sign. Amuset sign is nothing but a transverse laceration in the carotid intima. And with that, we are done with hanging. So what are the internal findings in hanging? So from outside to inside, remove the skin, you get subcutaneous tissue which is white and glistening. Remove the subcutaneous tissue, you get muscle where there is rarely ever any contusion or bleeding. Remove the muscles as well, then you get the thyroid bone which is broken at superior horn. You get the hyoid bone which is broken at greater cornu, and it is broken in case of greater than 40 years of age, because less than 40 years it is cartilage only in 15 to 20% of the cases. And the type of fracture is abduction fracture or side to side fracture. And then cricoid cartilage not really broken. Larynx, there might be hemorrhage. Then hanging from a long drop, you get vertebral injury. Number 1, cervical injury, where there is C2 or C3 or C4 fracture at pars interarticularis with slippage called spondylolisthesis. And at lumbar vertebra, there might be hemorrhage, which is referred to as Simon hemorrhage. And in carotid artery, within the intima of the carotid, there might be transverse laceration, referred to as Amoset sign. If you are an avid movie watcher, I know for a fact you already know everything about strangulation, because you get to see various ways victims get strangulated in movies. But then from examination point of view, entrance and university point of view, let's learn something about strangulation. Just like hanging, strangulation leads to asphyxia. And just like hanging, strangulation leads to asphyxia by neck compression. But in hanging, the constricting force is applied by the weight of the hanging body. But in strangulation, the constricting force is not by the weight of suspended body. That is, the constricting force is something else. And what is the constricting force then? Depending on the type of constricting force, you have strangulation of various types, which you'll learn about soon enough. But first, we are going to learn about the external and internal autopsy findings of strangulation. So external autopsy findings, I have divided them into 3. First, the external signs of asphyxia, which I have already taught you under the topic of asphyxia. You're going to see cyanosis and congestion. You're going to see Tordos spots or petechial hemorrhage. And then you're going to see voiding of urine, semen and stool due to loosening of the sphincter. Good, good. The same is true for hanging as well. Then you have external signs of force. See, if a ligature has been used to strangulate you, you're going to get a ligature mark. If hand has been used to strangulate you, you're going to get sixpenny bruise, sixpenny bruise. Then there are signs of external signs of struggle, which includes nose and ear bleeding. And see, when you are being strangulated with a ligature, you're gonna struggle against it. Try to release yourself from the strangulation, right, from the ligature. As a result, there is friction in between the neck and the rough ligature, leading to friction burn and blister formation. So there can be friction burn. So let's revise all these external autopsy findings. So first are signs of asphyxia, where you get congestion and petechiae. Just above the level of obstruction, there is congestion. Second, you have signs of force, where you get ligature mark if a ligature has been used and sixpenny bruise with nail marks if hand has been used. Then you get signs of struggle, nasal bleeding, ear bleeding and blister formation due to friction burn. Next, internal autopsy finding. And in any case of neck compression, I repeat, in any case of neck compression, you look at the internal autopsy finding on the basis of layers of the neck. See, you already saw the skin in external autopsy finding. Now you remove the skin, what do you get? Subcutaneous tissue. You remove the subcutaneous tissue, what do you get? You get neck muscles. You remove the neck muscle, what do you get? You get cartilage and bone. What cartilage and bone? You get thyroid cartilage. Then you get hyoid bone. And then you get cricoid cartilage. You remove the cartilage and bone, what do you get? You get the inside of the larynx. Subcutaneous tissue. Remember, in hanging, the subcutaneous tissue was compressed for a long period of time. That is why it was white, glistening, hard, parchment-like. But in case of strangulation, your neck is compressed with extensive force, right? In hanging, it was compressed with less force for a long period of time. In strangulation, it's compressed with extensive force. Since subcutaneous tissue is compressed with extensive force, it becomes soft, red, and hemorrhagic. In case of hanging, neck muscle didn't show any contusion and hemorrhage. Here, due to extensive force, there is contusion and hemorrhage of the neck muscle. In thyroid cartilage, like in hanging, here also there is superior horn fracture. In hyoid bone, just like hanging, here is also the greater cornu fracture. But in hanging, there was abduction fracture or side to side fracture. Here there is adduction fracture. Makes sense, because in strangulation, you are compressing the neck inside. So if the greater cornu fracture, it will move inside, leading to adduction fracture. Cricoid cartilage, if there is extensive force, you might be able to appreciate cricoid cartilage fracture. And in case of larynx, there is bleeding in the anterior and lateral surface. But remember, if posterior esophageal surface is bleeding, then that is not due to trauma. That is Prinsloo-Gordon artifact. What is Prinsloo-Gordon artifact? I have already explained under the topic of hanging itself. And to avoid Prinsloo-Gordon artifact, what do you carry out? You carry out bloodless dissection. What is bloodless dissection? Bloodless dissection is such a dissection where the brain is the skull is opened first, and then the abdomen is opened, and then the neck is opened at last. Revision time. So what is this? There is strap muscle. Strap muscle refers to the infrahyoid muscle of the neck. Strap muscle contusion. What is this? This is strap muscle hemorrhage. What is this? There is thyroid and hyoid fracture. What is this? The superior horn, right? The superior horn of thyroid cartilage is fractured. What is this? There is laryngeal bleeding, laryngeal hemorrhage below the level of vocal cord, below vocal cord, in the anterior surface, anterolateral surface. What is this? This is Prinsloo-Gordon artifact, where there is bleeding in the posterior surface of the esophagus. Artifact, Prinsloo-Gordon artifact. Okay, now the more fun part. Okay, so you have various types of strangulation depending on the various methods of neck compression. If a ligature is used, we call that ligature strangulation. If hand is used, we call that manual strangulation, also referred to as throttling. If bend of elbow or the anterior aspect of forearm is used, we call that mugging. If bamboo sticks are used, we call that bansdola. If iron cuff is used, we call that garroting. Okay, revision time. What is this? Here, ligature is used, so we call that ligature strangulation. Hand is used, we call this manual strangulation or throttling. Bend of elbow is used, we call this mugging. Bamboo sticks are used, we call this bansdola. Iron cuff is used, garroting. Starting off with ligature strangulation. Ligature strangulation leads to ligature mark. Now you need to be able to differentiate ligature mark due to hanging and ligature mark due to ligature strangulation. See, ligature mark due to hanging mostly was what? So mostly the hanging is via a fixed knot and a fixed noose, because people, they don't know how to make slip knot and a slip nose with a runny nose. So the ligature mark is oblique, incomplete, there is gap with suspension peak and above the thyroid, because even though the ligature is below the thyroid, due to the weight of the suspended body, it slips upward. But in case of strangulation, see what is there? I'm strangulating myself. What is this? It is complete, it is transverse, and it is above or below thyroid, depending on where I strangulate, above or below, but mostly below thyroid, because below thyroid I can feel the strangulation even more. So it is complete, it is transverse, it can be above or below thyroid. Now, it can be oblique in one case. Which case? You have seen in movies lots of time. If you are strangulated, right, and then dragged behind, as you are dragged behind, the ligature becomes oblique. So if you get dragged behind, you might have seen in movies where victims, they are strangulated or neck is wrapped with a ligature, then the ligature is tied to a vehicle, the vehicle runs and the victim is dragged on the ground, right? There you get oblique ligature mark. You need to be able to differentiate ligature mark from pseudo ligature mark. Pseudo ligature mark. Pseudo ligature mark is not due to strangulation, it is due to skin fold. For example, in case of obese and elderly. Okay, manual strangulation leads to 6 penny bruise. 6 penny bruise you can see right here. So there is bruising due to the thumb of the fingertips. Fingertips lead to bruising, and the nails, they lead to scratch abrasions or nail marks. You can see that only one hand has been used here. There's the thumb and then the rest of the 4 fingers. Both the hands have been used, thumb and then the rest of the 4 fingers, thumb and then the rest of the 4 fingers. You can see right here, you can see bruising due to the fingertips, nail marks, and bleeding from the nose as well. Next is mugging, which is of 2 types. If the anterior aspect of forearm is used, we call that chokehold, which leads to compression of your airway tract, trachea. Trachea gets compressed. If you use the angle of the elbow, then that is referred to as a carotid sleeper. Carotid sleeper. So here, as the name suggests, what is being compressed on both sides bilaterally, the carotids are compressed. Carotids are compressed, leading to cerebral hypoperfusion. Here is bastola, where the neck is compressed in between 2 bamboo sticks tied at one end. But there are other ways to perform this as well. 2 bamboo sticks pushed against one another and in between sandwiched is the neck. Or the same thing, 2 bamboo sticks tied at one end and then brought closer to one another, approximated, compressing the neck. And then there can be one method where the victim is against the ground and the bamboo is pushed against the victim, as you can see right here. Then there's garroting. This particular type of garroting that I have shown you with the help of picture is your Spanish windlass technique, which was used in Spain and France. It is a variant or a type of garroting, and the use was for judicial punishment or judicial execution. Judicial execution. Other ways garroting can be performed is with the help of this iron string. It is wrapped around the neck and then pulled. The neck is wrapped around and then force is applied in the neck, and with that we are done with the various types of strangulation. So we are done with hanging and strangulation. Up next we have suffocation. Just like hanging and strangulation, suffocation is also a type of asphyxia. But hanging and strangulation were mechanical asphyxia. Suffocation can be mechanical asphyxia or traumatic asphyxia. That is because in hanging and strangulation there was neck compression, but in suffocation there is no neck compression. There is no neck compression. Then what leads to asphyxia? Asphyxia is caused by obstruction to airway. And depending on the level of obstruction, you have suffocation of various types. Here's the respiratory tract with various levels of obstruction. If the obstruction is at the level of nose and mouth, we call that smothering. If the obstruction is at the level of oropharynx, we call that gagging. See, there is no neck compression. Again, no neck compression. Obstruction at the level of windpipe, we call that choking. Obstruction at the level of chest due to trauma, traumatic asphyxia. Obstruction at the level of chest due to abnormal position or posture, postural asphyxia. Postural asphyxia. First, smothering. Smothering is of two types. You can have accidental smothering and homicidal smothering. Accidental smothering. Example number 1. Newborn with intact sac. You can see that the newborn has an intact sac which is compressing over his nose and mouth. Second, intoxicated person falls face first on mud, sand or pillow. As a result, his nose and mouth gets blocked and he is unable to breathe, and he is not conscious enough to protect himself from that condition as well because he is intoxicated. Then homicidal smothering. It can be either with the use of hands or without the use of hands. Without the use of hand, you can use pillow to smother someone. You can use towel or you can use a plastic bag. But then, if you use hand to close someone's nose and mouth, that will lead to injury around the mouth and around the lips. That is, there will be perioral injury and lip injury. So with that, smothering is done. Then at the level of oropharynx, you have gagging, where a gag is stuffed in mouth. And this gag eventually goes behind and blocks the oropharynx and nasopharynx, leading to asphyxia. Choking. This is when there is accidental entry of foreign body in windpipe. As a result, we get an emergency condition where the person who is choking is unable to breathe, unable to talk, and you will find the choking person to be holding his neck with both his hands like this. And when you get that, when you see that the person is choking, you perform Heimlich maneuver. Then, traumatic asphyxia. In traumatic asphyxia, what happens? Either building collapses over your body, or people run over your body like in stampede, or a small baby is entrapped in between bed and the wall accidentally, referred to as wedging. In all these three cases, what is happening? Collapse, stampede, wedging. The chest is mechanically fixed. Since it is mechanically fixed, the chest does not expand, the lung does not expand, and inhalation does not take place, and the person dies of asphyxia. In traumatic asphyxia, above the level of obstruction, you get a face, right, that has congestion or ecchymosis. And since it seems as if the victim is wearing a mask of ecchymosis, so we call this mask ecchymosis. The reason being, when there is trauma over the chest, there is compression over the chest, sudden compression over the chest. This pressurizes the superior vena cava, and the blood from the superior vena cava returns back to head and neck. And there is increased pressure in the capillaries they burst, and the blood pools out, and which leads to congestion of head and neck above the level of obstruction, and gives up that mask ecchymosis or mask ecchymotic. Then postural asphyxia. This is due to posture, and there are two abnormal postures. First is jackknife. See, this person was trying to enter through this narrow window where he got stuck. The position is jackknife, just like a jackknife, due to which the viscera, the abdominal organs, they fall down, push against the diaphragm and prevent the expansion of lung. So lung does not expand, the person does not breathe, and the person dies. Another is reverse crucifixion, the opposite of crucifixion. Crucifixion. In reverse crucifixion also, the viscera, the abdominal organs, they drop down, push against the diaphragm and does not allow the lung to expand. The person is unable to breathe and the person dies. Now, we have a combination of smothering, that is when your nose and mouth is closed, and traumatic asphyxia, that is due to trauma, your chest is unable to expand, there is mechanical fixation of the chest. These are of two types. Number one is homicidal and number two is accidental. In homicidal, we have something called barking. In accidental, you have something called overlaying. In barking, you can see that, so the nose and mouth is of the victim is closed, right? That is your smothering. And the person sits on the chest of the victim, so the chest is unable to expand. That is traumatic asphyxia. This is barking, a combination of both. Overlaying is when a larger person accidentally overlays or lies over a smaller person, and the smaller person is unable to breathe. So the mouth and nose of the smaller person is covered, smothering, and the chest is also mechanically fixed by the heaviness of the larger person. So traumatic asphyxia. So those are the various types of suffocation. You had smothering due to covering of nose and mouth, which can be accidental or homicidal. You had gagging, where gag was stopped in the mouth, which closed the oropharynx and the nasopharynx. You had choking, where there is accidental entry of foreign body in the windpipe and the person is unable to breathe, holds his neck like this, you perform Heimlich maneuver. Then traumatic asphyxia, where the collapse of the building over the body, or stampede, people running over your body, stepping over you, or wedging of small baby in between the bed and the wall accidentally leads to mechanical fixation of the chest, and this also leads to mask ecchymotic. Then postural asphyxia, where there are two abnormal postures, jackknife posture and reverse crucifixion. Then combination of smothering and traumatic asphyxia, which includes homicidal, barking and accidental overlaying. At last, I want to give you one concept of cafe coronary syndrome. What is cafe coronary syndrome? First, cafe coronary syndrome is seen in intoxicated, someone who is highly drunk in a bar, or elderly, or obese. Because in these three types of people, there is reduced gag reflex. So let's say foreign body aspirates in windpipe. What will happen? There is going to be suffocation. But since there is reduced gag reflex, there is no signs of choking. There is no signs of choking, no signs of choking. As a result, the person dies suddenly. There is sudden death, and the death is due to, since there is food in the windpipe, and the windpipe has the recurrent laryngeal nerve. The food irritates the recurrent laryngeal nerve, which in turn irritates the vagal nerve, and this leads to vagal inhibition of heart. So you'll find an elderly who has died all of a sudden, and it seems as if he has died of myocardial infarction. But in actuality, it is not myocardial infarction. It is due to suffocation due to foreign body aspirated in the windpipe. That is why the name cafe coronary. The coronary is a misnomer. There is nothing to do with the coronaries, the coronary artery. The elderly has died due to suffocation. Cafe coronary syndrome, the same thing in pediatrics, is referred to as Kress coronary syndrome. And with that, we are done with suffocation as well. We have finally reached the very last topic under asphyxia. And even though it is the last topic, It is probably one of the most important from both entrance examination and university paper point of view. And that topic is drowning. So I want you to listen to me very clearly because I'm going to make the concept behind drowning crystal clear. Starting off with the definition of drowning as always. Definition. Drowning, just like hanging, strangulation and suffocation, leads to mechanical asphyxia. But here, asphyxia is not due to neck compression. It is due to the submersion of body in a liquid medium. Now, this submersion can either be complete or partial. That is, your body does not have to be completely inside the liquid medium to be drowning. Even if just your face is inside the liquid medium, just your nose and mouth is inside the liquid medium, that is enough to kill you by drowning. Mechanism behind drowning. So let's say I'm walking beside a deep lake and I accidentally fall in that deep lake. And yes, most of the cases of drowning are indeed accidental. Once I fall in the lake, what am I going to do? I'm obviously going to hold my breath in order to prevent the entry of water inside my lungs. But just for how long am I going to hold my breath? Eventually, my body will ask for oxygen. Eventually, oxygen will run out. My body will become hungry for oxygen, referred to as air hunger. Once there is air hunger, my body will involuntarily inspire. Involuntarily inspire. As a result, there is entry of air, but there is also entry of everything around. That is, there is also entry of water. And it is the entry of water that leads to death by various consequences. So the consequences have been broadly classified into two. The first consequence is where as soon as the water enters inside the respiratory tract, it enters the larynx, it irritates the vocal cord, and the vocal cord, it shuts off. This is referred to as vocal cord spasm. As soon as vocal cord spasm takes place, water is unable to enter. Water is unable to enter. So there is no entry of water. Yippee, you are safe, right? No, because along with water, there is also no entry of air. And if there is no entry of air, aeration of blood will not take place. And what do you call when there is defective aeration of blood? You call it asphyxia, and there is death by asphyxia. This right here is referred to as dry drowning. It is referred to as dry drowning, aka atypical drowning. Why is it called dry drowning? Because the water does not enter inside the lungs, so the lungs are relatively dry. So what's happening in short? Water enters inside the respiratory tract, it enters the larynx, it irritates the vocal cord spasm takes place, water is unable to enter, but along with that, air is also unable to enter the lungs, it does not reach the lungs, aeration of blood does not take place, asphyxia happens and you die. Second consequence is when water actually enters inside the lung. Water enters lungs. And when that happens, we refer to drowning in such case as wet drowning. Because here, as the water has entered the lung becomes wet. This is also referred to as typical drowning. Now, the consequence under typical drowning is further divided into two. And this is on the basis of amount of water that enters inside the lungs. What? On the basis of amount of water that enters inside the lung. In first case, comparatively less water enters inside the lung. That is 4 ml per kg of water enters inside the lung. In the second case, comparatively large amount of water enters inside the lung. 16 ml per kg of water enters inside the lung. So when 4 ml per kg of water enters inside the lung, this is what happens. The wall of the alveoli from inside is lined by surfactant. When 4 ml per kg of water enters inside the lung and then inside the alveoli, it washes off the surfactant. It washes away surfactant. Now it is the surfactant that is responsible for maintaining surface tension. So if surfactant is washed away, there is loss of surface tension. And when surface tension is lost, the alveoli collapses. Once alveoli collapses, exchange of gases won't take place and the person dies of asphyxia. Good? Good. This is what most commonly takes place. But sometimes there can be rapid flow of water, of large amount of water inside the lung, and that will lead to consequences as a result of 16 ml per kg of water entering inside the lung. Now even this is of two types, depending on the type of water that enters inside. Again, first you had wet drowning leading to two different consequences on the basis of amount of water that enters inside. For 4 ml per kg of water, we saw the consequence. Now we are looking at 60 ml per kg. Now within 60 ml per kg also, we have two different consequences depending on the type of water that enters. So whether it is fresh water or if it is salt water, that is sea water. You know very well that fresh water is hypotonic and salt water, it contains lots of salt, so it's going to be high in concentration, so it's hypertonic. And from your college days, you must remember this concept that in osmosis, the flow of water always takes place from hypotonic to hypertonic. Remember this, water flows from hypotonic to hypertonic. And if you know this much, just this single line, that water flows from hypotonic to hypertonic, you can interpret the rest of the consequences of these drowning on your own. See, let's compare both. Okay, so in first case, there is entry of fresh water inside the alveoli. This is the alveoli, surrounding which this is the capillary of the alveoli. Here also same thing, alveoli along with the capillary of the alveoli. In first case, there is entry of fresh water. Fresh water is hypotonic, so it moves from inside the alveoli to inside the circulation where the concentration is higher. As a result, there is hemodilution. Blood becomes dilated. Hemodilution. Hemodilution also leads to, since there is addition of water in the blood, the volume of blood increases. So there is hypervolemia. Since there is increased volume of blood, now the heart has to work harder to pump that excess blood. So there is increased workload of heart. Second, what happens? What else is inside the blood? There is plasma and there are your RBCs. The RBCs are also comparatively hypertonic. So the water from the plasma, the extra added water from the plasma also enters inside the concentrated RBCs. As a result, the RBCs, they swell up and they become fat and eventually burst. As the RBC bursts, the potassium from inside the RBC leaks out. And you should know that inside the cell you have more potassium and outside the cell you have more sodium and chloride. So if the cell bursts, all that potassium from inside the cell will leak out, and that leads to hyperkalemia. It is due to the combined effect of hyperkalemia and increased workload of heart that there is death due to ventricular fibrillation. Chill. All right. Second is what happens when salt water enters. When salt water enters, you know that salt water is hypertonic and water moves from hypotonic to hypertonic, that is from plasma inside the alveoli. So the alveoli gets filled with lots of water leading to pulmonary edema. Pulmonary edema leads to respiratory distress, and respiratory distress eventually leads to death by asphyxia. What about inside the circulation? So the circulation has become concentrated because all the water from inside the plasma has gone into the alveoli. So the plasma becomes concentrated, that is hemoconcentration. Due to hemoconcentration, two things happen. Number one, in case of hemodilation, due to addition of water, there was increase in the volume of blood. Here, during hemoconcentration, since there is loss of water from the plasma, there is decrease in the volume of blood, referred to as hypovolemia. And this can lead to death by hypovolemic shock. Second, since there is loss of water from the plasma, the concentration of ions in the plasma increases, and I have already told which ions are present outside the cell in plasma. They are sodium, chloride, magnesium. So as the plasma becomes more concentrated, who else is affected? Obviously the RBC. In this scenario, since the plasma is more concentrated, the water will move out of the RBC. As a result, the RBC shrinks. So the shrinkage of RBC has taken place due to increase in the concentration of these ions, leading to increase in the concentration of plasma. And these are the various consequences that lead to death and drowning. Let's revise them once. Okay, so I'm walking beside a lake and I accidentally fall in the lake. First, I will hold my breath to prevent the entry of water inside my lung. But eventually, I will be hungry for air. So my body will involuntarily inspire, leading to entry of air, but along with that entry of water as well. It is the entry of water that leads to death by various consequences, which is broadly categorized into two. In first consequences, referred to as dry drowning, there is no entry of water inside the lung. Here simply the vocal cord shuts off. As a result, air is not able to enter in, water is unable to enter in, and the person dies of asphyxia. In second consequence, there is wet drowning where the water actually enters the lung. This is further categorized into two types depending on the volume of water that enters inside the lung. First is when only 4 ml per kg of water enters inside the lung. When 4 ml per kg of water enters inside the lung, then inside the alveoli, it washes away the surfactant of the alveoli. So the alveoli loses its surface tension and the alveoli collapses, leading to death by asphyxia. In second case, when lots of water, large amount of water enters inside the lung, what happens? That depends on the type of water that enters inside. First, we have fresh water, which is hypotonic. Since fresh water is hypotonic, water moves from hypotonic to hypertonic. So water moves from inside the alveoli to inside the circulation. As a result, the circulating blood becomes dilated and the volume also increases due to extra added water. Since there is increased volume of blood, the work of the heart to pump it also increases. There is increased load on heart. Along with that, the extra added water also enters inside the RBC. So the RBC swells up, it bursts, and all that potassium from the RBC leaks out, leading to hyperkalemia. Due to the additive effect of increased workload of heart and hyperkalemia, the person dies of ventricular fibrillation. Second case is where there is entry of salt water, which is hypertonic. Since salt water is hypertonic, water moves from inside the plasma to inside the alveoli. As a result, there is pulmonary edema, respiratory distress, and death by asphyxia. What about inside the circulation? Inside the circulation, since there is loss of water, the plasma becomes concentrated. Along with that, there is also decrease in the volume of blood itself, which can lead to hypovolemic shock. Due to increase in concentration of the plasma, now the water from inside the RBC leaks out. So the RBC shrinks and gets damaged as well. Hopefully you have understood, and not hopefully, I'm pretty confident you have understood the mechanism behind drowning. Now, some very important terminologies. There is death by drowning, where the body has to be submerged in water for it to die, either completely or partially. Now, this is different. Here, in hydrocution or immersion syndrome, there is death due to body fall in water which is cold, and the temperature is 5 degrees Celsius less than the body temperature. So when someone jumps into water, into cold water, and the temperature of that cold water is at least 5 degrees Celsius less than the temperature of that person's body, it can lead to following consequences. So let's say first, the person is emotional, right? Second, the water enters the tympanic membrane, or it enters the larynx, or it enters the pharynx. Or in case of duck diving, where you dive head first into the water, or when there is a sudden blow to epigastrium, that is when you dive chest and belly first into the water, there is blow of water, cold water on your epigastrium. In all these consequences, what eventually happens is that eventually they all lead to activation of vagus nerve that leads to vagal inhibition of heart and eventually death. So here death is occurring due to various mechanisms that are as a result of cold water, not the entry of water, but due to the coldness of water. Second is secondary drowning or post-immersion syndrome or near drowning. In these cases, the person dies not because of drowning, but because of complications after the person has been saved from a near drowning situation. And these complications can be hypoxic ischemic encephalopathy, metabolic acidosis, electrolyte imbalance, or aspiration pneumonia. Now we are going to learn about the external and internal autopsy findings in case of drowning. First is froth. The froth is mushroom shaped. It is fine in consistency. It is white in color. It is tenacious or mucoid. It is large in quantity, that is copious, and it is persistent, that is it continues to come out even after wiping, even after you wipe the nose and mouth with a cloth, the froth will still continue to come out of the nose and mouth when you apply little bit of pressure on the chest. Because this froth is not coming out of larynx, pharynx, it is coming out of lung itself. So as soon as there is froth inside the lung, it will keep on coming out. So how exactly is froth formed in the lung in case of wet drowning? This is how froth is formed. See, so this is the alveoli, right? In case of wet drowning, there is entry of two things. There is entry of air and there is entry of water. The water, it irritates the mucosal lining, As a result, there is increased secretion of mucus. And inside alveoli, what you already have is surfactant. So now you have all the ingredients for your recipe, but then you can't cook your food. To cook your food, you need to process all these recipes together, and that process is referred to as churning. What is churning? Churning means all these ingredients, they need to be mixed together. And for that to happen, there has to be some struggle in the drowning victim. And that is only present when it is an ante-mortem drowning. Let me explain. Listen. When you are alive at the time of drowning, you will struggle to come out of that situation. And as you are struggling, there is rapid movement of the body and movement inside the lung as well, or the churning of the lung. As a result, these ingredients, air, water, mucus and surfactant, they get mixed inside the lung, leading to the formation of froth. So, froth coming out of nose and mouth is an important sign of ante-mortem drowning, a way to differentiate ante-mortem drowning from post-mortem drowning. One concept I want you to remember, your life will be easy. See, whenever there is any sign of struggle, I repeat, sign of struggle, then that will immediately suggest it to be ante-mortem drowning. For example, in this case, due to struggle, there was froth formation. So froth is a sign of struggle and it indicates ante-mortem drowning. See, a person can only struggle if he was alive at the time of drowning. If he was dead or unconscious, then he would not struggle, and that would not be referred to as conscious ante-mortem drowning. Okay, second is cadaveric spasm. Cadaveric spasm is as a result of struggle again, struggle. And whenever there is sign of struggle, it is seen in ante-mortem drowning. What type of struggle? Trying to hold on to anything, grass, mud, whatever. See, when you are alive at the time of drowning, you try to hold on to anything to come out of that situation. You hold on to grass, you hold on to mud, and after death, you get spasm such that your hand is clenched, your fist is clenched, and you are holding on to that piece of grass and mud. This may not be always present, but if it is present, it is a sign of struggle and it indicates ante-mortem drowning. Third is goose flesh, goose skin. This is due to contraction of erector pylorem muscle. As the erector pylorem muscle contracts, the hair, like in case of goosebump, it elongates, it straightens up. This is washerwoman hand/feet, seen due to imbibition. Okay, first it is seen in fingertips, then it is seen in palm, then it is seen behind the hand, and then finally in the sole. This is important because this gives you the time since immersion. That is, if you see wrinkling of the fingertip, the immersion was probably for 3 to 4 hours. If you see bleaching of the cuticle, the immersion was probably for 12 hours. If you see soddening, it was probably for 24 hours. And if you see cuticle starting to separate off from the palm, fingertips and sole, the immersion was probably for around 48 hours. Okay, then the internal autopsy finding. So in external autopsy finding, we saw signs of struggle, the external signs of struggle that indicate ante-mortem drowning. Those were froth and cadaveric spasm. And then we saw non-specific signs like goose flesh or goose skin and washerwoman hand/feet. Internal autopsy finding, obviously you are going to go ahead and examine the lung, the most important organ to be examined during drowning. Now let's say this person went through wet drowning, right? The water has entered inside the lung. The lung is going to be, number one, voluminous, because it is filled with water. Obviously it's going to be full of volume, and as it is filled with water, it's going to be heavy and boggy. Not only that, as it is filled with water, voluminous and large and distended, it is going to push against the ribs. So you will have indentation of ribs or the rib marks. Number 4, when you remove the sternum during dissection, the lung balloons out. It balloons out on its own. This is what you get. Okay, in case of wet drowning. What is this? This is Poltov hemorrhage, which is seen in the lower lobe, in the anterior surface, just behind the pleura or subpleural. So these are subpleural hemorrhages, referred to as Poltov's hemorrhage. And Poltov's hemorrhage is as a result of struggle. And again, as soon as you get a sign of struggle, it indicates ante-mortem drowning. All right. Now, you need to be able to differentiate between ante-mortem drowning and post-mortem drowning just on the basis of lung findings, right? So, ante-mortem drowning can be of two types, either conscious ante-mortem drowning or unconscious ante-mortem drowning. If it is a case of conscious ante-mortem drowning, that means the person was conscious and alive at the time of drowning. Unconscious ante-mortem drowning means the person was alive but unconscious at the time of drowning. And post-mortem drowning means the person was already dead at the time of drowning. So if you look at the lung, in a conscious person, at the time of drowning, the person is gasping for air. So he inhales air and water. So you get emphysema aquosum. That is, there is air as well as water. Since there is air and water and there is struggle, there is churning and there is froth formation. In unconscious person, however, there is simply flooding of water inside the lung. The person is not gasping for air because the person is unconscious. So you get edema aquosum. There is simply flooding of water. Flooding of water. And since the person is not conscious, there is no struggle and there is no froth formation. In case of post-mortem drowning, you simply get hydrostatic lung. Chill. All right. Now, let's combine our knowledge from both external autopsy findings and internal autopsy findings and the various tests to differentiate ante-mortem drowning from post-mortem drowning. Starting off with the external autopsy findings or the external signs of struggle, that is froth formation and cadaveric spasm, is indicative of ante-mortem drowning. They are not present in post-mortem drowning. Number 2, trachea and bronchi, if they contain mud, silt, diatoms, algae, that means it is most probably ante-mortem drowning. In post-mortem drowning, they are not present. Talking about lung, the lung, number 1, shows Poltoff's hemorrhage. In ante-mortem drowning, because it's a sign of struggle. Post-mortem drowning, the hemorrhage is absent. In ante-mortem drowning, the lung is voluminous, heavy, boggy, distended. But in post-mortem drowning, the lung has collapsed. In ante-mortem drowning, you get, since there is struggle, air hunger, there is entry of air and water, you get emphysema aquosum. However, in post-mortem drowning, you get simply hydrostatic lung due to hydrostatic pressure. Stomach and intestine can contain mud, silt, algae in ante-mortem drowning, and they are absent in post-mortem drowning. Water in middle ear is present in ante-mortem drowning, but it is never present in post-mortem drowning. In middle ear, water is never present in post-mortem drowning. Diatoms and Gettler test are positive for ante-mortem drowning, but they are negative for post-mortem drowning, which begs the question, what exactly is diatoms test and Gettler test? So let's learn about them. There are two very important tests that you need to know under the topic of drowning, and they are the diatom test and the Gettler test. Diatom test allows you to differentiate ante-mortem drowning from post-mortem drowning. That is, whether the death took place by drowning or was the person already dead and his dead body was dumped in water. That is, whether the person was alive at the time of drowning or not. Before understanding the test, you need to know what diatoms even are. They are nothing but unicellular algae which are found in various sources of water. And these unicellular algae are of various types or various species. But what's common among all those types is that they are covered by a layer of silica. And this silica is important because it makes diatom resistant to acid, resistant to heat, and resistant to decomposition. This is a very important point and really significant for diatoms test, and I'll tell you exactly where this point holds significance. But before understanding the test itself, you need to know the mechanism or the relationship between drowning and diatoms. So here is the body of water, let's say a lake. And this is me beside the lake. I accidentally fall into this lake. So as I am drowning, what enters inside my lung are the water as well as the diatoms that are present in this water. So if it is a case of wet drowning, I repeat, if it is a case of wet drowning, then what enters inside my lung or what enters inside the alveoli of my lung are water as well as the diatoms present in that water body. Now these diatoms are really minute, around 40 to 100 micrometer in size. So they can easily cross the respiratory membrane and enter the capillary. Inside the capillary. Now, if I am alive at the time of death, right? And that is the situation. I am alive and then I dropped down accidentally in the lake and then now I'm fighting for my life, right? I'm alive at the time of drowning. If I'm alive, my body's circulation is intact. As a result, the diatoms that are inside my capillary gets distributed to the rest of the body by the pumping of the heart or due to circulation. It gets distributed to kidney, it gets distributed to liver, it gets distributed to spleen, and it gets distributed to bone marrow. Let's take a second scenario where I am already dead. That is, someone has killed me. Someone has killed me. And then this someone dumps my body into this lake. What will happen? As I am drowning, water will enter inside my alveoli, diatoms will enter inside my alveoli. The diatoms are really small, so they can cross the respiratory membrane and reach the capillary as well. But in second case, I am dead. So my circulation is no longer there. There is cessation of circulation due to death. As a result, the diatoms in the capillary does not get distributed to the rest of the body. So there is no diatoms in kidney, there's no diatoms in spleen, there's no diatoms in liver, and there's no diatom in bone marrow. So this is how you can differentiate ante-mortem drowning from post-mortem drowning. That is, if it is a case of ante-mortem drowning, I am alive at the time of drowning, then the diatoms get distributed to kidney, liver, spleen, and bone marrow. So if I take a sample of bone marrow, treat it with acid and heat and observe it under microscope, I'll be able to appreciate diatoms. On the other hand, if it is a case of post-mortem drowning, that is, someone has already killed me and then dumped my body in this lake. In that case, the diatoms in the capillary does not get circulated to kidney, spleen, liver, or bone marrow. In this case, if I take the sample of bone marrow, treat it with acid and heat, and then observe it under microscope, I won't be able to find any diatoms. So let's see how exactly the samples are treated and the test is carried out. First, we take a funnel. Inside this funnel, we put that sample tissue, which is usually your bone marrow. Let's say it is a case of ante-mortem drowning. So there are going to be diatoms inside this bone marrow due to the distribution of diatoms by the presence of circulation at the time when the person was alive. To this sample, I add nitric acid. And to the same sample, I also apply heat. Due to heat and nitric acid, the tissue dissolves, but the diatoms remain intact. Why? Because Diatoms are resistant to acid and heat, as I said earlier. This is the significance of layer of silica around diatoms. Then I take the sample, put it in a centrifuging machine, and then take the sediment. After I have put it in a centrifuging machine, and then observe this sediment under a microscope. Under a microscope, I will be able to appreciate the diatoms. But the test is not done. For us to truly determine whether it is a case of antemortem drowning or not, we also need to take the sample of water from that lake, from the very lake containing the diatoms. So we take the sample of this water and then observe it under microscope. Observe the diatoms and then compare the diatoms of the sample water with the diatoms of the sample tissue. If they match with one another, then this is a case of antemortem drowning and the drowning took place in this very lake. So that's your diatoms test. Again, what is diatoms test? Diatoms test is carried out with the help by keeping diatoms as the main source of test. Diatoms, they are unicellular algae found in various sources of water. They are of various species, but what's common among all those species is the presence of silica lining those diatoms, which is resistant to acid, heat, and decomposition. If it is a case of antemortem drowning, then the diatoms that reaches the capillary gets distributed to various organs due to the presence of circulation when the person is still alive at the time of drowning. But if it is a case of post-mortem drowning, since the person is already dead at the time of drowning, there is no circulation and the diatoms in the capillary does not get distributed to rest of the organs. How to carry out the test? You take the sample tissue and treat it with acid and heat, and then observe it under a microscope after centrifugation. If diatoms is observed and these diatoms are the same as that in the water sample as well, that means the person died of drowning and where the drowning took place is the very same lake. Second is Gettler's test. Gettler's test is carried out in order to differentiate between saltwater drowning and freshwater drowning. In Gettler's test, you actually take two samples. So you take one sample from the right side of the heart and the other sample from the left side of the heart. Normally, both right side of the heart and the left side of the heart have equal concentration of chloride ions. However, in case of freshwater drowning, as you know from your pathology of freshwater drowning and saltwater drowning, which I have already taught under the pathophysiology of drowning, freshwater drowning leads to hemodilution. Since dilution of the blood takes place, the concentration of chloride ion in the left side of the heart falls because the left side of the heart is in direct communication with the lungs, and it is at the capillaries where the concentration of chloride ion is falling down due to hemodilution due to freshwater drowning, and the concentration of chloride ion on the right side of the heart remains the same. So overall, the right side of the heart contains more chloride, higher concentration of chloride ion. In saltwater drowning, there is hemoconcentration. As a result, the concentration of chloride ion on the left side of the heart increases, and on the right heart side of the heart remains the same. So overall, on the left side of the heart, there is more concentration of chloride ion. See, the difference in chloride ion is significant only if the difference is greater than equal to 25 milligram per 100 ml of sample. Now, instead of using chloride ion, you can also use strontium, and the logic is exactly the same. And if you use strontium for evaluation, this is referred to as strontium test. And for strontium test, the difference in concentration of strontium is significant only when the difference is greater than equals to 75 microgram per liter of sample. And with that, you are done with Gettler's test as well. And with that, we are done with drowning, and with that, we are done with the complete topic of asphyxia.